right, should we get started? Fantastic. Well, welcome everybody. Welcome those here in the room. Welcome online. We're so excited that you joined us this morning. I think we say this every year, but the summer just goes by faster and faster, and there's so much excitement at the beginning of the summer when everybody joins and gets here, and this is the culmination of that work. And after today, it just like the Olympics. It's the event's done, and then there's this sort of big letdown. But I think everybody on with this group is getting gold medals for the amazing work that you've done. Thank you. I just want to start with some thank yous first and foremost, because it literally takes a whole village for this to happen. And what I love the most about it is that it's always just meaningful work. This is not just let's sort of do a research project. Let's just play around with some data. The projects that the interns have been working on have and will have a real impact on the populations that are being served by those in Dallas, particularly those that have fewer resources, that are underserved. So to me, what's just the most meaningful is the impact of the work. First and foremost, I want to thank the interns. You guys have been just amazing to work with. You always bring so much energy every day to the office. Your creativity, your passion, your insights have just been tremendous, and certainly has elevated our work through your contribution. So thank you for everything that you've done. And this is just one step in this journey. Second, I would like to thank the PCCI team, who goes above and beyond every year to be able to make this happen. And I don't know if there's anybody in the company who at some point during the summer have not helped, have not contributed, but particularly the core committee that puts all of this together from early January, from the recruiting through the interviews, through onboarding, and then through the actual work. So a huge thank you to, I'm going to try this. I'm going to leave somebody else. I've already asked Albert to help me. But Capria, Albert, Hannah, Yusuf, Jackie, Mike, Alex, Aaron, thank you. Thank you. You put so much into it, and it's visible. I would like to also thank our partners at Parkland and PCHP, because without your partnership and giving us the opportunity to contribute to the work that you do, giving us access to the data to make this work meaningful, this would not happen, or not happen to the same level of impact. So thank you. Thank you, our colleagues online. Thank you to the teams at Parkland and PCHP. And last but not least, a huge thank you to David and Laura Sachs. They've been part of this journey with us since day one, 5 years ago. This is the 5th year anniversary of this. And we're so appreciative, because one of the key things that we will embarked on a mission, on a journey to do, is continue the legacy that Michael started, and continue to bring forth opportunities for women in data science and technology, which he was so passionate about. So David, Laura, thank you so much. David, I'll ask you to say a couple of comments in a second. The last thing that I would say is every detail matters, and all of you have put so much into not only the work, but into how you actually sharing that work. From the look and feel, and we're sharing a brand new look and feel, so hopefully you will all enjoy that, to the page numbers, which we always say every year, because that was something that Michael always stressed. But every single detail matters in everything that we do. So thank you for being so due diligent and doing all of that. I'm excited to get to the presentation, so I'm not going to say anything else. I'm going to be taking notes. I'm going to be cheering you on and learning throughout the process. But before we start, David and Laura, on behalf of both of you and the whole Sachs family, do you mind sharing some comments from your end?
Well, on behalf of Laura Sachs and myself and the Sachs Family Foundation, we are so proud and to be able to support this program and support your further education within healthcare data science. Michael was ahead of his time at SG2, empowering and helping women further their career in healthcare and in data science. One thing that he would always say is the past does not predict the future. And you have an opportunity to look in the data and see different trends to help impact healthcare delivery and hopefully also reduce the costs of healthcare for everyone here in this country. Just keep moving forward, and we know you will be successful, and we're very excited to hear the presentations and what you found this summer looking through the data. And as Steve mentioned, always put those page numbers on, because he would love to jump around in a presentation to healthcare leaders and point one thing out and then go to a different slide. So don't be afraid to go in between slides and deep into the key points and the key things that you found interesting within your research. So enjoy your time, and we're looking forward to hearing about your success in future years. Thanks.
We're going to do 4 presentations at 15 minutes with a 5-minute Q&A, so 20 minutes total. We've got our first 4 presenters up here, and then we'll take a small 10-minute break, and then we'll come back and do the final 3. Just one final comment. Just want to especially thank the mentors who had helped the interns as well, Alex, Reshma, Sandra, Arun, and Yusuf. The interns were required to be in person 3 times a week, which is something that we did a little bit differently this year. Instead of being fully remote or fully in person, some of a hybrid. And the mentors were there for most of the time. I know especially Alex was there, I think, almost every day. Helping all the interns in their presentations. So enough about that. Let's get into the main event. So here's the agenda for what we've got for the 7 presentations. Yeah, we'll dive right in with Oscar. Oh, one final thing. If you have questions, save the questions until the end. We'll come around for those in the room with the microphone. And then for those who are online, please put them in the chat. We will filter or potentially combine some similar questions if there are similar ones, and we'll read those off. So.
Good morning, everyone. Thank you so much for coming today and listening to our presentation. It's a privilege for us to share our work. My presentation today will include 5 main sections. I will first talk about myself and then about my internship journey, especially about PCCI. It was a surprise that I added to the presentation. It's not about my research, but I'm sure you'll like it. And then I will talk about the problem and the solution and my key takeaways. About me, my name is pronounced as Özgür. It has 2 letters that doesn't exist in English alphabet. It's hard to say. And it means independence and freedom in Turkish. I live in Kopel. I am a member in the Kopel Community Garden organized by City of Kopel, and this is me doing the organic gardening. I have 2 cats. This is really a photo from UTD's Instagram page account, #CatsOfUTD. I brought them from Turkey. This is Besat. They are siblings, by the way. They don't look like siblings, but they are. And I am a certified barista, and it happened to me to drink only my coffee, so I'm not sure whether it's a good idea. I am an industrial engineer by education. I worked in the industry over a decade in banking, especially in IT and process engineering departments. And then I fell in love with data science. I came here to US to pursue a PhD in data science at UT Dallas. My advisor was here last year, And immediately after the presentation, he called me and he said, I know you will love it. And so I continued to follow the postings. This is a really premium internship. So please let your all loved ones know it, follow it, and apply for it. I was blown away because in my industry life, I had interns, but I was like, I'd never treated them like this. So I'm sorry, past interns. Because they have special intern sessions only for us. 5 non-technical sessions, also technical sessions, and also sessions with Parkland Health. We went to the hospital. We saw the homes toured, like those moving hospitals. It was amazing. And I never had the chance to see those places in live when I am at school. And we also had the chance to join all PCCI events. I think this also shares the culture of the company. Like we weren't treated as interns. We were legitimate employees here. I want to thank my mentor. He's an amazing person. He's very knowledgeable, a very good person. I want to thank Alex. He was in the office every day, and I'm a cat who likes to work from home, so I really want to thank him. I want to thank the team, Capriya, Ashley, Jacqueline, Hannah, Albert, and Steve, for making this happen, for making this internship, and other mentors. They always answered my questions as well. Michael and Aaron for polishing our presentation skills. Shujat for letting me add 2 applications on my CV. Tim and Nathan, you really want to pay that salary. I know it. Joseph S. and Mohammed and Thomas. So amazing sessions. Thank you so much. I learned a lot. Wenki, Estefania, Holt, Wensi, and Ole. Amazing discussions I had with you, and I hope to stay in touch. And lastly, Crystal, we all miss you. I hope you are watching this. So now here you see 2 photos of me. I lived in this apartment in Istanbul. I know you're jealous. This is me with tea in my hand. And this is my hometown. I know you're more jealous. So life there seems like I don't have anything chilling, but no, I had chronic illnesses. I had hypoglycemia, and unfortunately, I had to end up in ER. One day I fainted while I was driving. I was in panic. But someone in ER tapped on my shoulder and said, do you know this is preventable? And I didn't have any attack for more than 10 years. I didn't visit ER. And when I saw the one-pagers, I said, I have to be in this project because there are people in my family who suffer from hypertension and diabetes, and they don't need to suffer. So in this journey, I spent my first 4 weeks learning about diabetes and hypertension from the physician medicine view, not from the caregiver view. And next 7 weeks, I spent learning the algorithms, how I can predict better. And this week, we wrapped up the presentation. I got feedback from Albert, Yusuf always, every time. Michael, he likes feedback. Thank you. And we also prepared an impact analysis with Yusuf. We are talking about dollars. I hope I keep you awake till that moment in presentation. So chronic disease is super important. It's a big problem. Leading cause of death, 90% of healthcare costs in the US, and it's top community health concern here in Dallas. Among them, hypertension and diabetes are like the top, and these diseases end up emergency department visits, and they don't need to. Here in Dallas, you see the sums. In 2019, 250,000 people visited ER. This makes 9.4% of the population. This is a lot. We don't need to have this, and we believe this is avoidable. So we prepared a 4-step mechanism. First one, we can't prevent what we can't measure. So we have to analyze the data, and we have to understand the high-risk geographies. Next, we have to predict the future. But what shall we do with this prediction? We have to create a surveillance system. And lastly, if we are able to prevent those people visiting ER, we will be able to diminish the load for ED visits. we will create space for other patients, and there will be cost savings, and we can spend this money more clever for other healthcare issues. This looks amazing. To start with, we need data and a good algorithm. So what do we need for a good algorithm? This kind of prediction problem requires a time series data. What it means, you observe only one thing, ER visit, but through the time. We have monthly data. We began this project with zip codes as a starter with diabetes. So we have 91 zip codes, so 91 versions of this data. So imagine you fit a model to one of these, but it has to predict at the same time for 91 of these. So for this one version, we need a consistent trend. You can't predict if the data is always increasing and starts to decrease at one time. We need the variability also to be consistent, the ups and downs. And lastly, as we are fitting a model to 91 zip codes at the same time, this variability and the trend should be consistent across the zip codes. Now I want to ask you a question. Do you think it's consistent across zip codes? Who says yes? Thank you. You make my life easier. So let's start with the trend. 6 zip codes, highest deviation and lowest deviation. Pay attention to the red lines. Do you see any similarity? No. Warning, difference in trends. They are not even like in the same direction, rising, decreasing, horizontal. Let's move to the variability. This bar chart represents monthly averages for each month, the green bar charts, and the red line represents the deviation within the month across zip codes. Let's focus on January. In January, for a zip code, can be minimum 10 or 170 for a zip code. Warning, highly volatile. I want to steal these 2 blue lines because I will use them on the other slide. And the middle one represents all zip January average, and the top one represents January maximum. Now let's check the regions. We divided zip codes into North, Center, and South Dallas. And this blue line, as I said, all zip code max, all zip code average. North Dallas, significantly lower than average. Center Dallas, similar-ish. South Dallas, always higher. Warning, regional differences. So now we reached the 5th week of my internship. I'm panicking. I have an assignment and Yusuf tells me, relax, welcome aboard, you are in PCCI. We developed 353 models. I wasn't aware we did this much amount. And we tested on 50 plus feature sets. I counted it, actually it's even more, but I thought you may think I might exaggerate. So I wrote constant numbers here. We evaluated our models using a measure called root mean squared error. This measure actually takes the difference of the prediction and the actual value, squares it, calculates it across all time points, takes the average, and takes the root. The best performing model was ARIMA. And if it's 10, it means when we predict the future, for a point for all zip codes, we are minus plus 10 on and off. This is good. I was surprised, and thank you, Yusuf, and Albert, and Alex, and Arun, and everybody. Okay, I will need another 2 minutes. I stopped thanking. What's next? What do we do with this? What's the implication? We have 2019 predictions in our hand. We said, let's focus on South Dallas zip codes and measure the impact. What happens? For this analysis, I will first set the grounds for some assumptions. We were off by 200. Can I hear the drum rolls and claps? Thank you. Our data set didn't have any patient identifier, so we assumed each ER visit represents one patient. This is a strong assumption. Actually, it punishes our prediction, but I'm fine with it. We assumed one ER cost is $5,000. And one community health worker, I had a chat with Estefania about the life of a community health worker, and I'm like, it's a great job, it's an amazing job. And we assumed each community health worker spends 30 minutes for a patient. This, to cover the number of patients we predicted, we need 7.5 community health workers in a year. We assume 3 scenarios for hourly cost, $30, $50, $100, because Estefania told me we may go and visit them, we may call them, so we don't know. 3 different options. So this makes $2 million or $7 million a year. To break even this cost, even in the most expensive one, if we can decrease 1,400 ED visits, we are done, we are okay. This is amazing. Why don't we do this? I will even motivate you more, because we are in PCCI. What if we decrease by 20% or 30%? I punished our calculations by decreasing the amount we spent for community health work and for our 200 misprediction. Still, we are net off by $30 million, $47 million, $12 million in each scenario. And this makes, we can hire 14 more community health workers, or we can create space for extra, like 10,000 ED visits. So this is amazing. My key takeaways are, first, we can and we should mitigate diabetes and hypertension. I want other people to experience what I experienced. And high volatility in ED visits and its relation to social determinants of health. I have more slides, more figures. We only picked North, Center, and South. It's mind-blowing. I want to learn more about this. And in the interview, when Ashley, Capria, and Yusuf talked me about the company, I literally asked them, what you are telling is too good to be true. Is this true? Yeah, it's a blunt question. They said, yes, it's true. And I said, I want to spend my summer with such people. And yes, it's true. Thank you so much for this opportunity. I'm a happy member of this family, and we will all miss you. And the interns are amazing. I'm sure you will enjoy their presentation. Questions?
Any questions from the audience or in the chat? Oh, I have a question. Your analysis went through 2019. I know the answer to this. Why just stop at 2019? I don't even know if I told you why we stopped at 2019.
Well, we checked 21, 22, 23. The data is missing in 20. We don't have any data for COVID. And for 21, 22, 23, these are claim data sets. I see they are not yet settled down. That's why we didn't want any COVID effect, and we didn't want any missing data point. That's why we focused on 16, 17, 18, 19.
That's right.
Good morning, I'm Teresita Oaks, and I'm very impressed with this work. We use it a lot for the community health needs assessment, and I am delighted to see that you analyze and stratify by the zip codes, because that is our headache. And I was wondering, did you look at this from a population breakdown by race and ethnicity?
No, not at the beginning. We focused on zip codes. Not at this level. Yeah. I mean, we have some analysis, but we did the impact analysis by population. Yeah.
Definitely a next step. Anything else in the chat?
Alex has a question. I like his questions.
When you're talking about the model performance and looking at you ran the optimization and you're like looking across different models, do you find Arima won by like a landslide, or were there other models that were close? I'm just curious.
With your and Yusuf help, other models got closer. What Arima does basically, we are able to predict the 12 months, but with the supervised learning models, we were able to predict the next month by using only 2 months. And their MSCs got closer. And interestingly, social determinants of health brought noise to the model. I was very surprised.
Last question.
It was good. Thank you so much for a wonderful
you.
presentation.
Thank you.
Just really, really impressive and well articulated. It's more of a practical question. So you created a great prediction model. What are anticipated next steps in terms of its use and how we can apply it to
Sure.
intervene sooner?
The next steps would be expanding this model to hypertension, and also expanding this model to a data set that will be obtained from Parkland. And I will be happy to hear this being deployed.
Perfect. Oh, one more question. Okay.
No, I just wanted to have one quick comment in this, but I just wanted to say what an amazing job with the presentation overall. We changed the template mid-session and you fully embraced the template and had great fun with it, I see. So I just want to applaud you for that. One of the best presentations I've seen here at PCCI
Thank
for our
you.
interns.
The coming ones are greater.
Awesome. All right. Thank you, Oscar.
Thank you so much.
Next up, we have Sarah.
I just want to see it. I'm going to look at from here. I appreciate it. Hello, everyone. Good morning. My name is Öykü Öz, and today I'll be talking about the risk prediction model. Today, I'll be explaining a little bit about suicide and suicide statistics. I will be going on the literary analysis I focused on within the first few weeks of my internship. I'll be talking about the methods and materials I used and my results, and I will focus on my future steps. But first, let's get to know me a little bit. As I mentioned before, my name is Öykü Öz. I am currently doing my bachelor's degree in computer science and data science at SMU. And as you can see in this picture, I have been very interested in computer science ever since I was 4 years old. I am an international student from Turkey. This is my 3rd year in the United States, and my family lives all the way back in Turkey. I love Dallas so far, and I'm enjoying it. In my free time, I really like traveling, spending time with my family and friends, and taking pictures. Okay, now let's dive into my project and my project background. First of all, before I start, I want to ask you guys, how many people do you think die by suicide each year? Any guesses? 2 million? 200,000. Those are high guesses. Okay. So according to CDC data, 48,000 people died by suicide in the year of 2021. 12.3 million people, adults, considered suicide, and 1.7 million actually attempted it. Suicide is the 10th leading cause of death in the United States, and 1 person dies from suicide every 11 minutes, which is very unfortunate. Looking into the general background, I found in my literary analysis that 77% of the people saw their primary healthcare provider within the 12-month prior to their death, and 24% of them saw a mental care health provider. 30% of the individuals had a healthcare visit
within the 7 days prior to their death by suicide. This means that people were within the area of healthcare before they unfortunately died by suicide. Parkland launched the universal screening in the year 2015, and ever since then, every patient who visits Parkland has been screened for suicide if they're age of 10 and above. Parkland does this very differently than other hospitals because every patient who comes to Parkland is screened for suicide. So even if you go there for like a broken toe or something else, you're screened for suicide. The goal of this project is to save lives by possibly predicting suicide with previous risks and by using the clinical, non-medical, and demographic information that was provided in the data set. And we're trying to find answers to questions like, is it possible to build a suicide prediction model with the data set that we have? And how much signal is there to predict suicide within the data set? In the literature review background that I did within the first 3 weeks, I've concluded that sex, poor physical health, chronic illnesses, contact with psychiatric services, marital status, alcohol misuse, and previous self-harm history may have an effect in suicide. Males are 3.7 times more likely than females to die by suicide. Single, widowed, or divorced people are twice as likely to die by suicide as married people. Suicide is 1.63 times higher among individuals who misuse alcohol, and 1 in 6 people repeat self-harm. My methods and materials include the suicide dataset that was provided to me by the Parkland EHR, and it contains over 3 million rows. I have a total number of 83 futures, and my dataset includes information from March 2014 to March 2021. My mortality data is received by state, and it contains information from March 2014 to March 2020. And the tools I've used is Python for coding, Seaborn for visualization, and Databricks for the coding environment. The project objective and timeline included an exploratory data analysis using the suicide dataset that was provided to me, finding correlations between the features and the suicide relations, and creating a suicide risk prediction model with logistic regression. Now let's jump into my results and the progress. I'm going to go on with the exploratory data analysis, and in here you can see information about my row data set. As I mentioned before, I had total number of encounters of a little bit over 3.4 million, which is a lot of encounters. And I had a total number of unique patients of over 623,000. I had total number of suicide deaths of 567, which is very low compared to the data that we have. 67% of my patients were female and 33% were male. Here you can see the age representation in my cohort by sex, as you can see. And now I'm going to talk about the correlations I found after my exploratory data analysis. Here you can see a percentage of female and males percentages that died by suicide within my data set. And as I mentioned before, in the literature review, there were males were 3.7 times more likely to die by suicide compared to females. But in my data set, I've concluded that males were 5.18 times more likely to die by suicide after coming with my new data. Now, let's talk about the previous suicide-related diagnosis. Previous suicide-related diagnosis includes suicide ideation, self-harm, and previous suicide attempts. The total number of patients that had suicide-related diagnosis in my patient was 4,680 patients. And 3,211 of my patients had multiple suicide-related diagnoses. That rounds up to 21.87% of the patients actually repeating the suicide-related diagnosis within the data set that was provided to me. 18.47 of the patients who died by suicide had previously suicide-related diagnosis as well. These correlations helped me what to know to focus on when I was doing my modeling data set. Later on, we focused on the previous encounters prior to suicide, and I found that 47.8% of the patients visited the hospital within the 12-month period prior to their suicide death. Now, let's move on to my modeling results. My modeling dataset creation included filtering my data with age, sorting the data, and then deleting the unnecessary columns from my dataset because I had 83 columns. I did end up creating more columns, but first I did deletion. I added my reference dates for the creation of the history, and then I did future engineering using correlations. I calculated medical history, I added a homeless shelter flag, and I added diagnosis flag. Finally, I had my modeling dataset ready. My modeling dataset included a predictive target of that patients that die by suicide with binary classification. My patients were only considered of adults, so I had only 18 and above of age for patients, and I had a total number of 82 columns that I created. I had a total of 528,887 patients and only 448 suicide deaths. Here you can see the patient demographics I used when I was creating my columns and the suicide-related data that were included in my modeling data sets. Now I'm going to be talking about the steps I used for modeling. First, I split my data for 80% training and 20% testing. I did machine learning processing, which include hot one encoding, normalizing, imputing, and scaling my data. I used subsampling because I had a largely imbalanced data set because of the number of suicides. And I used majority undersampling, which is in a 1 to 100% ratio. I did future selection using variance threshold. I did model optimization via good search. And finally, I evaluated my performance metrics. Here you can see the results of my model. My model ended up having a balanced accuracy of 74.7%, a sensitivity of 82.2%, and a specificity of 67.2% after all of the feature selection and edits that were done. Here you can see the confusion metrics and the ROC curve for my model. I had an AURC of 0.81. And this is how my model used to perform before feature selection, because as I mentioned before, it was a largely imbalanced data set. After doing the feature selections with the coefficients that are provided here, my model ended up performing way better than it used to. So the limitations and challenges I include, as I mentioned, one of them was data set imbalance, but me and my mentor, we did the best we could with subsampling and balancing the loss function. Complexity of suicide was also one of the limitations because even though we have a lot of features that is provided to us by Parkland with the data set, it is still suicide has a lot of background and psychiatric information that may not be captured in the data set that we have. And the reliance on patients' responses we're screening for is one of the results too, because not everyone answers not the right, but the actual way in some of the screening. Future opportunities for my project include fine-tuning and including additional features for model, applying advanced machine learning methods, and increasing data set size with additional years to possibly have, unfortunate for the reality, but good for the data science perspective, to have more suicide patients in the data. And to conclude, I have completed a literature review and found similar results in my data set with the literature review. Then I did an exploratory data analysis to find the features that correlates with suicide within my data set. Finally, I developed a model with an AURC of 0.81, a balanced accuracy of 74.7%, and a sensitivity of 82.2%. Thank you so much for your time and listening to me. I would especially like to thank Alex and Jackie for all their help. This project wouldn't have been possible without their help. I would also really like to thank the PCCI team. This was an amazing opportunity, and I'm really glad to be a part of this internship. I can't wait to use what I learned within this past few months in my future life. Thank you. Are there any questions?
And a quick note for those online, the chat is intentionally disabled. There is a Q&A section, and that's where you should put your questions and answers. Or
Thanks.
questions, not answers.
Good work. Thank you for that.
Thank you.
What did you find that was the most surprising corollary to your analysis? Or what the surprising corollary to the suicide or the intent to commit suicide?
I would say I was surprised by the fact that male were like very more likely to die by suicide compared to female. That was like an astonishing fact for me because I didn't know that before doing the literally analysis. And after like concluding that within my data set too, I think that added up to it. So I would say that was one of my like biggest shocks. Any other questions?
It's fabulous work and so meaningful.
Thank
Thank you. Have you found any of the non-medical drivers of health, which is sort of, I'll consider the life stressors, to be a key importance into the model predictions, or is that future work to be explored?
That some part of it is future work. In my literally analysis and background check, I have found results like academic status, like possibly those types of things may have an effect on it, but we don't necessarily have that like information in the data set. With like we have the addresses, and that was included in the model with like longitude and latitude, but yeah, and then that may be possible future work. Yes, thank you. I appreciate it.
So the CVC, I know this is like very project oriented. The CVC data wasn't included in the PO, so we couldn't include it. But we're working on including it in the future. Additionally, I'm happy to talk to it. Do you want to speak a little bit on the longitude and latitude,
Longitude and latitude.
or would you rather me talk to it?
What do you want me
Okay.
to specifically?
We in her defense, we had a nice conversation, probably 30 minutes yesterday. One of the key features that came up, both when she was working on the correlative analysis as well as the modeling, was latitude and longitude, right? So encounter year, latitude and longitude. And we did find some like fairly good signal in where the patient lives because we have their address, which correlates with the CVC features, but we couldn't use them directly.
You. So to pick up a little on that longitude and latitude, it's probably true to say that the environmental context, the physical and social environment have a big impact. So had you thought about maybe what facets of the environment that may be of interest?
Yes, but as I said before, we don't have that information directly in our data set. The only information that we have about the environment is the longitude and latitude, and that was included in my model.
So if ever you did want to extend this, I don't know if you will be, but we have like about 100+ environmental contextual things if ever you are interested.
Thank you.
Right, last one.
I have a question, and I can't remember the numbers exactly, but I believe you said that in your literature review, you found that men were more likely to die by 2.7 versus women. But when you did your analysis, you found that men were more likely 5.7. Is that
Yes.
correct? Can you tell me a little bit? Yeah, that's the one. That to me is very significant because you're using partly data. Can you explain a little bit why do you think you had that difference?
So what is like even more shocking is, as I mentioned before here, we have 67% female patients and we have 33% male patients. Even within that ratio, men were still very, very likely, more likely to die by suicide compared to women. And this is just like the comparison of the percentages that are taken up out of like the deaths of suicide.
Yeah, but what I think it's interesting that you found is that in our population, it's higher.
Yes.
That to me is concerning because that is a disparity that needs to have further assessment is really what I'm trying to say. So thank you for that because
Yeah, of
that to
course.
me is concerning.
Yeah. We were also very surprised with it. Like, because even 3.7 times is like high and having it like 5.17.
All right, thank you so much.
Of course. Thank you for listening. I'll just go to the end so it's easier.
Emily, you're next, right?
Yeah.
Awesome. All right, here's Emily again.
Morning, everyone. So today I'm going to be talking about current progress in my project for predictive social determinants of health analysis of maternal outcomes. But before we discuss the specifics of the project, let me introduce myself more formally. I graduated this May with a master's in computational and applied mathematics at SMU, hence the happy picture on the right. And I also interned here at PCCI last year using the same PCHP cohort that I'll discuss later, but a different predictive model. And here's a picture of me, the other interns, and the mentors from last year. Before I begin, I just want to say thank you so much for having me as an intern last year and giving me the opportunity to come back and hopefully present some very interesting results today. And so, now that we've introduced ourselves, let's talk about why PCCI and PCHP should focus on creating models for preterm birth. Especially in the last couple of years, the preterm birth rates and the infant mortality rates in Texas have been rising. And we know because of that there's a much higher risk for ED visits during or after delivery. And that one major factor that determines this is whether or not patients are uninsured or underinsured. And because of social determinants of health factors that create this socioeconomic disparity and health disparities, that these patients might lack access to adequate prenatal care during their pregnancies. And while PCCI and PCHP have been making great progress in addressing this with the preterm birth intervention program, which is a predictive model that identifies high-risk patients, which allows us to establish a line of care, just as it's important to find those individual patients that are at risk, it's also important to understand for the wider community what are the major drivers for preterm birth. And so that's going to be my focus. So this summer, I'm taking the first step in creating a predictive model for using PCHP claims data within the 7 PCHP service counties to predict preterm births on a block group level. And the long-term goal that PCHP wants to strive for is to create an interactive dashboard that allows users to see model results, major drivers for a block group, etc. And so for the remainder of the presentation, I'm going to introduce our PCHP cohort, talk about some relevant information pertaining to them. I'm also going to talk in detail about my predictive model, especially since it's not the most standard type of predictive model you might have heard before. And then I'll introduce some next steps. So first, I'm going to introduce our cohort and the data sources used for the predictive model. The first is the PCHP claims cohort, which is composed of historical data from 2015 to 2019, and it is composed of 66,000 deliveries and 58,000 unique mothers. This data set excludes stillbirths and multiple gestations, particularly because multiple gestations we know already has a higher risk for preterm births, and we want to focus on those single gestations. The second data source I'm using is the CVC, which, to vastly oversimplify it, measures vulnerability in community due to socioeconomic and health disparities, whether that's at zip code level, block group level, etc., using 4 different indices shown here. And so, now that we've familiarized ourselves a little bit about these data sources, I'm going to briefly touch on some cohort demographics. The first is ethnicity. As we can see here, the vast majority of our cohort is labeled as other or Hispanic. The reason why other is our top ethnicity is just due to the nature of how PCHP claims are reported. And I hope in the future that this process changes so that we can get a more accurate picture of what our ethnicity for our cohort is, because we want to make sure that our predictive model promotes fairness and mitigates bias. And also, there's research that already shows that ethnicity is a key factor in preterm birth rates and infant mortality rates. Looking next at age, since that is also a major factor for preterm birth, we see that the average age of a woman in our cohort that is delivered is 26 years old, with a minimum of 13 years old and a maximum of 54 years old. And lastly, we have our actual premature birth rates, which is ultimately what we're trying to predict with our predictive model. As we can see, we have a 17% premature birth rate, which is higher than both the Texas average and the Dallas average. And keep this 17% in mind, it's going to come up later. And so, taking into account, now that we know a little bit about our cohort, let's establish where our cohort is located within the 7 PCHP service counties. As we can see, looking first at the chart on the left, the majority are located in Dallas County. So I'm going to go ahead and zoom in here on the right and find our top 10 zip codes. And as we can see, the majority of those top 10 zip codes are in Southeast Dallas, with a couple of hotspots in North Dallas or West Dallas. And taking an even closer look is looking at the number of patients for each block group. So as we can see, and we'll talk about the ramifications of this later, that the number of women in each block group in our cohort is quite small, with a mean of 19, a median of 15, and with a range from 1 person to 144 people. And we'll find out later why this is something that needs to be addressed more in the future. And lastly, let's touch on the CBC again. So now that we know where a cohort is located, and we keep in mind that our cohort is widely spread out in all these 2,200 block groups, let's look at the CVC, the overall CVC index, which is measuring overall vulnerability due to those socioeconomic and health disparities. And we see that the majority of those top 10 zip codes have either very high or high vulnerability. And so for me, this was very important to know that yes, we should be using the CBC as features for our predictive model, since it's indicating to us, okay, there is disparity here for the majority of our cohorts, and this could be important features for predicting preterm birth rates. And so let's get to the predictive model itself, which I'm excited to introduce. But first, let me touch on the features. There's 51 total features that I could be drawing from the CVC and the claims data, and this is from 2,200 block groups in the 7 counties that PCHP services, and it's composed of 4 major factors. We have demographics and social aspects, such as like the age of the mother or the number of gaps of insurance. Then we have mental and behavioral health, healthcare service utilization, and obstetric history and medical comorbidities, which includes both acute and chronic conditions that are associated risk with preterm births. So now let's get into the model itself. So just as a reminder, the goal of the model is to create a predictive model for predicting premature birth rates in a block group. Since we want to predict the actual rate, we want to use a regression model. But spoiler alert, a standard regression model is not the best fit for this problem, and I'll discuss why. So looking here on the left, I have a distribution of the premature birth rates that I'll be using for my model, and as you can see, it looks quite strange. First, we have this distribution of zeros. This is not surprising. We have a 17% premature birth rate, and all of these women are distributed in all these 2,000 block groups, and we remember that the average is quite low. So the chances of a block group having no premature births is higher than you would expect. So we can see we have almost 400 of those block groups are just composed of zeros. And then we have the second distribution, which is composed of all the block groups that do have premature births. And so you might be thinking, why wouldn't a regression model work for this? Well, if you train a regression model on this, it has to train on the zeros, train on the non-zeros. It's not going to do a good job at training on both of those. And so what's going to happen is you're going to have a regression model that just performs subpar. It can't really decide how to focus on the data. And so using tools from data science, I'm going to build a special model that'll help the regression model focus in on those non-zeros in particular and make better predictions. And I'm going to do that with something called a hurdle model. You don't need to know anything about a hurdle model. I'm going to step you through everything. So the goal of the hurdle model is that we're going to improve upon standard regression results by breaking up this problem into two simpler pieces. Step one, we have a classification model, and all it's going to do is state, does a block group have a premature birth rate? If it does not, if it predicts a 0, the final outcome is 0. But if it says, okay, there is a premature birth rate, we're going to feed all of that data into the regression model and then end up with our nice, hopefully focused in premature birth rates that we want. So I'm going to step in and talk about each step of the hurdle model and its results and talk about some challenges. So first, it's a classification model. It's a binary classification where we predict either 0 if it's 0, or we predict 1 if it's not 0. And this is the hurdle that's the namesake of this model, because it determines whether the final output is 0 or non-zero. And for our results, we see it has under 75% balanced accuracy, which is good. There's signal in this problem. That's exciting. And I'm going to, using this confusion matrix, tell you what data is going into the next step, the regression model, and which data is going to just end up being 0. So this maroon box here, these are the true negatives and the false negatives. So the model said this is 0. The final output for this is going to be 0. This blue box here, which is composed of the false positives and the true positives, are going to be fed into the regression model as follows. So step 2 is the regression model. We're going to take all those false positives and true positives from step 1 and feed it into this model here. And we can see the results are quite funky, but I'll explain what happened. So looking here at this scatter plot, which is plotting the actual values that we know and the predicted values from the model, we see two different things happening. First is the blue box, which is composed of a vertical line, which says the actual prevalence is 0, but predicted non-zero. And that's a consequence of feeding in both true positives and false positives. Those false positives created this line of error. But promisingly, we can see outside of that box, we have this positive correlation. And for me, this was fantastic because all summer I saw plots where there were no correlation. And let's discuss a little bit why this is happening. In particular, why the size of the block group is affecting regression. So here's the same plot from the last slide, but there's two different points, red points and green points. Those red points, which are block groups that have 10 or less patients, we can see the majority of those block groups that have very little patients comprise that vertical line and these outliers. And why this is happening? Well, when you have a block group with very few patients inside of it, that data is going to be more noisy. And when data is noisy, it distorts the regression model and you end up with these funky vertical lines. But promisingly, most of the block groups that have over 10 patients, we can see are mostly in that positive correlation. So that implies to me, like, okay, not only is there signal in this problem, in our regression problem itself, we know that if we can find a way to circumvent this and get more patients in each block group or do some other method to circumvent this, we can get much better results. Speaking of results, we should check what the hurdle model's final results actually are. As we can see, there's now actually two bars that are quite interesting. We have that vertical bar that popped up in step 2 with the regression model from the false positives. But because the classification model has false negatives and true negatives, those false negatives are going to pop up as a horizontal bar. So one bad thing about this model is while it's really good at isolating that positive correlation that we want for our regression model, we have that compounding error. So that's something that we need to be addressing in the future. Speaking of the future, some next steps is instead of using block groups or census tracts, we could cluster neighboring block groups, hopefully raising up that average number of mothers within each block group and fixing that issue with noisy data affecting regression results. We can maybe even ditch this entirely and run separate models for those block groups that have 0 premature births and block groups that have premature births. In addition, we can get some more PCHP claims data since it was only from 2015 to 2019. And then also in the future, redesign the model to be more interpretable so you can see those feature importances and know those major drivers. Thank you so much for listening to my presentation. And thank you to everyone at PCCI and PCHP for making this happen.
Thank you, Emily. Any questions?
Thanks, Emily. That was great. A real quick question. The slide where you showed the population below 10 versus over 10, would it any way help if the limitation or if you put a filter over the block groups over 10 as the block groups that you would consider?
I have been considering that, but let's see, going back to, let's see, I have to flip pretty far back in this presentation. 1 second, there we go. So we look at this distribution here, we notice, like if I decided, okay, I'm only gonna use block groups that have more than 10 patients, we're losing so much data. When I filtered out patients that only had one mother in that block group, I already lost 250 block groups. Since this distribution is so left skewed, there is concern of, okay, should we decide to destroy a lot of the data we have or try to collect new data instead or try to reformat this in some way so we don't lose out on so many important features from these block groups?
What are some new challenges you faced this summer as opposed to last summer?
Ooh. So last summer, I built a classification model. Classification models, I mean, of course, all models are difficult to build, but classification models, they're easier to like kind of fine tune. With regression models, it's challenging to, find the features that work for a regression model, being able to tune the hyperparameters to make sure it works well. And of course, with the funky distribution I had, having to see for weeks on end really sad regression models. And before this summer, I didn't know what a hurdle model was. I've never done it before. I built this hurdle model myself, so it was very rewarding to see me rise up to the challenge. And even though there's a lot to improve about the hurdle model and whether or not this in the end would be the right approach, it at least gave valuable insight to what the next steps should actually be. Oh,
What's the name of the distribution?
the name of this distribution, oops, it has a few different names, but the one I learned in grad school is a Tweety distribution. I remember when I plotted this graph, and I was like, wait a minute, this is like the bird. So thank you, grad school, for teaching me about this distribution so I can catch it earlier and know what approaches to use.
Yeah, we had some fun with the distribution names. If you exclude the 0, it looks pretty normal skewed left. And then if you go back to your block group count one, so we tried normal distributions for those. This is a Poisson distribution. Well, it was sort of a Poisson. It kind of rises and then falls, which is an interesting one, but you can't use that either. So it was, yeah, settled on the Tweety. Awesome. Yep. Last question.
You. So did you happen to consider any temporal aspects? Because like the time of year or how polluted it was when they were, about to give birth or conceived could make a difference.
That's a good question. At least with the data set I had, the only variable that had any time stamps was just the actual date of delivery. And so I also don't have too much experience in time series data. So at least for right now, maybe if I had more data and had more insights of not just the day delivery being my only timestamps that I have for my data, but that'd be something to consider for sure, because time series analysis would be very useful for this.
Yeah, gestational week by time of year, especially in Dallas. That's a good
True.
one. Okay, thank you, Emily.
Thank you.
Next, we'll have Sonia.
Um, sorry. Good morning, everyone. Hope you all are having a great morning today. I am Sania Safat, and today I'm going to talk about my project, which is PCHP asthma. First, before delving into the project, I'll give a brief introduction about myself. I'm a very shy person, so I would keep it very brief. I'm an international student from Dhaka, Bangladesh, and I came to United States 2 years back to pursue a bachelor's at the University of Texas Arlington. Although I came 2 years back, I started in mid of COVID, so I did my freshman year completely online. Yeah, but the good news is I'm actually graduating this summer within the very next few days, or already have graduated. I can say that with the honors bachelor's in computer science and engineering and a minor in mathematics. Yeah, and I'm very excited about it. That was all about me. So let's go into the project and the agenda for today. So first, I'm going to talk about what's the project's goal, what I'm working on. And then I'm going to talk how my work approach that I've taken to work on this project, and what are some of the summaries that I have drawn insights from, and finally conclude with my personal learnings as an intern working on this project and this internship overall. So about the project. Imagine a child full of laughter and happiness, but suddenly not able to breathe or play. That's the reality of asthma. Asthma affects around 6 billion children all over the United States and is the most prevalent chronic childhood disease. And not to forget about the cost, overall, half of the annual asthma related healthcare costs come from the ED and inpatient hospital visits related to asthma. But asthma is a care sensitive condition. And with accurate identification and in a timely manner, asthma related outcomes could be improved. And on that insight, PCCI has collaborated with PCHP to build a machine learning predictive model that identifies at risk asthmatic patients using clinically relevant features. And the model aims to help children aged between 6 months to 18 years. And some of the model risk categories that the model is identifying are low risk, medium risk, high, and very high. So, what's my project? What was my goal this summer? Basically, the main focus was to improve lives of asthmatic children. And how I'm doing this, I'm using the existing risk predictive model and analyzing additional data with this model. And the goal is to find out if there are any important factors in this additional data sets that might be helpful for the model in the future. So the roadmap that I'm taking while working on this project is first, I will be doing I did a model evaluation, understanding how the model is performing. And then I went into checking some additional data. The first one was asthma control test data, and then the spirometry data. The reason to choose this two as my additional data was because medically, these tests are conducted to identify cases of asthma. So model evaluation with emergency department visits. So first of all, in order to compare how the model is performing with actual visits of asthma into the ED, I took the 4 risk categories from the model, risk, very high, high, medium, and low, and grouped them into 2 buckets of very high and high together, and medium and low and the other one. And I'm comparing, and in the x-axis, you can see the predicted labels. And in the y-axis, I'm taking the actual ED encounter visits. What I'm seeing from this confusion matrix is that I'm getting 31% of sensitivity, which means that out of the total patients for whom we had model
evaluation of 20,000, 31% of the cases, the model is identifying correctly had a true positive case of ED visit. Next, what we saw is that if we just completely forget about the model, and I go on to see, based on who had an ED encounter, and try to find out whether that was a true positive or not, I might find an incidence of 1.8%. But using the risk predictive model, if I look into the categories where the model is saying, okay, the prediction is high and very high, and they actually ended up in the emergency department, that precision is 5.5%, which is threefold higher efficiency in identifying population risk. Next, we thought of regrouping the comparison a little bit, and I grouped the medium, high, and very high in one category and left the low category separately. And I did a similar comparison with actual ED visits, and this time I can see a better sensitivity. So the model is able to recall a good percentage of the data as true positives. However, the population, using the model, identifying true positive ED visits reduces to 4.1%, but it is still 2 times higher efficient. So let's go on to understand our additional data set, which is the asthma control test. So what is asthma control test? It is basically a questionnaire-based assessment to understand how the asthma is of a patient. And it includes some options, and based on the answer, and based on each option, a score is associated with it. And based on the answer from all the questions, a total is calculated. If the total score of a patient is above 19, out of 25 to 27, out of 25 mostly. If it is above 19, we consider it as a well-controlled asthma. And if it falls below 19 or equal to 19, we consider it as a not controlled or poorly controlled asthma. So once we understood what asthma control test was, the next goal primarily was to understand how the ACT was performing with our model predictions. So here we did this comparison, and in the x-axis, you can see we took the model risk categories, the 4 model risk categories. And if we focus on the low category, we have the highest number of patients. Not to mention that we had 222 encounters of patients who went for the asthma control tests out of the entire model population. And the maximum were in the low category. And we can see that the low, since it had the maximum patient, aligns pretty well with the ACT, where the prediction is saying, okay, someone will have a low risk of asthma. The ACT is also saying that 72% of that population is well controlled. However, if we shift our focus towards the very high, we see that out of the 10 patients who are considered to be high risk by the model, the ACT is still saying that 80% of them will have a well-controlled ACT. That intrigued us to see further whether the day gap between when the prediction was done and when the patient did the asthma control test had any significance. So here we can see that almost all the risk categories had a very wide range of around 750 days to 800, which is over an year. So further, we wanted to see and understand the timeline. So first we saw the people who had the asthma control test done before their prediction. And we saw in different timelines, 3 months, 6 months, and even a year back. And in every case, if you focus on the low category, the number of patients are higher. And it is still aligning, saying the same story, that when the prediction is saying to be low, the ACT is also saying a higher percentage of well-controlled. And then we moved on to see what's the case for the people who had a prediction after their asthma control test. Who had an asthma control test after their prediction to be done. In this case, since we're using summer data and it's very recent, we could only see up till 3 months after their prediction. And in this case also, although we had only 16 patients, the maximum were in the low risk category. And in this case also, we had a higher percentage of well-controlled ACT. Although the other risk groups did not align that well with the model, there were also not enough patients under those risk categories. So it wouldn't have been a fair comparison. The next step for the asthma control test that we wanted to do is compare how the ACT is performing with emergency department visits, just like we did with our model. In here, in the x-axis, we are taking the two outcomes of ACT, not controlled and well controlled, and we're comparing it with the ED visits. And here we can see that if we just didn't consider ACT to be done, out of the ED visits, we could have found 1.3% of the cases, but using ACT, we're finding 1.5%. Still, it isn't that much. So we can say that ACT is not probably performing that well in identifying cases of severe outcomes. So what are some of the summaries that I concluded with this ACT data? Comparing ACT with the model, we can see that ACT correlates pretty well in the lower risk categories of the model. And the next one that we saw is that the ACT precision, when we compared ACT with our emergency department visit outcomes, we saw there was no significant improvement in identifying patients with severe outcomes. And the next steps that could be taken for this data set that would be interesting to see is if we could examine by joining the ACT tests with the PCCI model together and evaluate that with emergency visits. Following on that, we'll move to our next data set, which is the spirometry data. So what is spirometry, first of all? It is basically a lung functioning test where the goal is to identify how well or how easily can you breathe in and out of your lungs. It is important, and it is an important test to understand if there are any lung-related disease. So some of the important metrics from the spirometry dataset that we found are the forced expiratory volume, FEV, forced volume capacity, FVC, and the ratio of FEV by FVC. For our project and from insights and research, we understood that the main thing to focus on was the FEV by FVC ratio, which says to be normal if the ratio is equal to or greater than the 70%. And if it's lower than 70%, it is considered as abnormal. Moving on, we did a similar thing just like before. We compared our spirometry outcomes with our model predictions. And in this case, we're taking the help of a box plot. So the first thing that we found out that when we went on to see what's the spirometry, how many patients we have for spirometry, we found only 64 of them who conducted the test. So more on that, as we understood that when the FEV by FVC ratio is above 70%, we consider it normal. We generally wanted to see a declining trend of the box plots where the lower risk would be at a higher level and the medium and followed by the medium and the high. Although the low and medium seem to follow that trend, the high is kind of off of that trend. But there are only 2 patients for the high risk category. So we cannot draw any final conclusion from here. So for the spirometry, what the insights that I took was it's a very valuable test and it has some very valuable metrics. The FEV by FVC ratio could be very important factor to understand if a patient who probably have asthma has any underlying lung condition or lung disease or not. But since there are not enough data, we're not able to understand the complete story of spirometry. So the suggestion or the insights that we draw is that more tests for spirometry should be done in order to understand its role and to compare it with the model. So finally, after analyzing all that and working on the project for 3 months, these are some of my personal learnings that I've taken as an intern. The first would be the application of data science. Like coming right out of the classroom where I just learned, oh, these are the models and this is how data science can help to prediction. It was really interesting to see how data science can actually help solving real world business problems. And technical communication, the ability to explain complex technical concepts to non-technical stakeholders is probably an important insight that I draw. And the most important thing that I understood from here is the storytelling with data, which is very important to comprehend what I have understood properly or with ease, which I have seen all the mentors do really well here. And I have observed that over the summer, and I constantly try to do that, and I'm practicing, and hopefully we'll get better. So that was all. Thank you all for listening to my presentation. I would like to thank PCHP for the data sets, for this valuable data, and PCCI for giving me this opportunity to present here today and for this internship. And I also like to thank the entire PCHP project team here at PCCI, particularly my mentor Arun and Dr. Yolande, who had helped me understand this entire project, the complexities, and like they actually taught me how to tell a story with the data and to comprehend things with ease. Thank you all for listening to me.
Any questions? Are they not using the chat? No? Good.
So with these I don't even know how you say that, spirometry data set, what do you expect with more data? What do you expect the trend to be in the box plots?
So for this parametry, we understand that the FEV by FVC ratio, which is the main thing, it needs to be above 70% to be considered normal. So when we say that the model is at a lower risk, we want to see that that box plot to be higher above, so that it's above 70%. So that aligns, that says, oh, when the model is saying that someone will have a lower risk of asthma, their spirometry is higher. So, and in a medium, that should be lower than the low risk category. So when the model is saying someone will have a medium risk of asthma, that is probably a little bit lower, probably a little bit higher than the 70%, but lower in the lower level than the low risk. And for the higher risk, since we are saying that someone will have a high risk of asthma, they should be below the 70% threshold.
Yeah, the spirometry data measures lung capacity. It's like a breathalyzer looking thing. So you have to, like, they say, blow in it for 10 seconds and as hard as you can and things like that. And so you expect a higher score, meaning the stronger lung capacity, to be lower risk. Lower score, higher risk is the assumption. But I think we had 2 in the high and very high category, like 0. Yeah.
2.
So we're looking at an overlap between the PCHP population and spirometry analysis done at Parkland. So the N is quite low. Still worth exploring. Yeah.
Thank you. That's very interesting. So when looking at where the model is struggling a little, as asthma is related to like a constriction of the airways and the inflammation, then the things that could be causing that inflammation, like pollutants or very cold temperatures and things like that, so that context may be very helpful in the model.
Yeah. So considering the environmental factors, that would probably be our next thing to look on, probably an additional data set from the CVC to look and compare how the model is performing with that one.
All right. Thank you. Next up, we have Verona.
Thank you. All right, my name is Verona, and this summer I was working on a project identifying potential patients for HIV PrEP in a jail setting. So a little bit about me. I'm a rising senior about to graduate this December, unfortunately, from UT Austin, getting a BS in computational biology. Saturdays in the fall, I love to do everything Texas football. And when I'm not at DKR, I love to be out on the water or in the water, anywhere but the heat. Okay, the project. So human immunodeficiency virus, HIV, is transmitted primarily through blood contact, so sharing needles, and it can also be transmitted through sexual contact, childbirth, and breastfeeding. Once a person gets HIV, there's no way of getting rid of it entirely. There are some medications and treatments that help reduce the viral load, and HIV damages your immune response. So when you get a new infection, it's harder for your body to fight that. So there are medications to kind of help with that, but there's no way of getting rid of it completely. There is a medication pre-exposure prophylaxis. So if you're taking PrEP before you come into contact with HIV, it's known to be 99% effective at stopping that new infection from taking hold of a person's body. Ending the HIV endemic has an initiative to reduce new HIV infections by 90% by 2030. So PrEP is definitely a key player in that goal. We know that 14% of all people with HIV pass through jails each year, so there's a lot of people at high risk of getting HIV in those environments, and that's why we want to target jails as a place to get people that need PrEP and get PrEP into those hands. And there's also a high turnover from jails back into the community, so it's a good stopping point to identify key patients for PrEP. So my goal is to identify PrEP candidates using a combined jail health records and also Parkland EHR data. And the reason why we want to also use Parkland EHR data is we know that at Dallas County Jail, about 66% of the patients there have also been to Parkland in the past. So there's a potential for there to be more information that could be insightful and help better predict the PrEP candidates. So our cohort, the people at Dallas County Jail that we're looking at, are adult patients with an HIV test from jail that have also been admitted to jail between 2015 and 2024. When we select for these things, we have about 76% males and 24% females. In terms of age, it's about 25 to 45 years old. The exact average is at 37. We also have a majority of Black patients and non-Hispanic. So the data that we're getting from the jail health records are 33,000 patients, and we also have 3.9 million patients from the Parkland Hospital side. We also have social history and encounters history, and that is between 2013 and 2024. So the first step for my project is matching, and the reason why that's its own separate step is because there's no key identifier between jail and Parkland. So when you go into jail, you don't give them your Parkland Hospital primary MRN, and vice versa. When you go to Parkland, you don't tell them this is my jail ID. So we had to match the patients based on the information we did have. The first thing I did was blocking by date of birth. So instead of looking at all 33,000 patients from jail and then 3.9 million Parkland patients, I got a subset of the patients that were born on the same date of birth. And then from there, I used the Levenstein distance, which is a string similarity metric, and it calculates how similar or different two strings are. And so I applied that to the first and last names between the two databases with a threshold of 0.75. So the highest score you can get if two strings are the exact same, if they put in their name perfectly in both jail and the hospital, they would have a score of 1. But a lot of times there's spelling mistakes. You might also have patients that have a concatenated last name and they only put in one last name at jail and then put down both at the hospital. So that threshold of 0.75 makes sure that we catch those patients, but also don't include patients that have completely different last names. With these two features, I was able to match 85.5% of the patients, and then I went on to confirm to make sure that they also matched ethnicity, race, and social security number. Social security number, I let that be a little loose, so only 6 of the digits had to match because I didn't want it to be too strict. I went back in and flagged for false negative matches, so patients that did have a perfect social security match, but for some reason didn't have the right date of birth, or maybe their strings, their name similarity was below that threshold. I flagged those as potential matches that weren't caught in my first run through. With this matching, I was able to confirm matches in 71.3% of the patients out of the 33,000 jail health records. With that Parkland primary MRN brought in along all of those jail patients, I was able to start pre-processing, bringing in the encounters and social history information from the Parkland Hospital. I made 53 new features, so that included dummy variables and also creating logic. And this data was between 2013 to their reference date based on each patient. I also wanted to mention that at this point I started learning and I used PySpark for a lot of this stuff. It was something completely new to me, but I was having a lot of issues with runtime and the size of the data. So PySpark uses a distributed computing environment, and it was a steep learning curve, but definitely beneficial. All right, so with the features all engineered, I ended up with 339 features for 24,000 patients. And two things to note before I started making the model, some obstacles I had. I only had 1.9% of the patients with a positive HIV test. So that means I had some really imbalanced classes, and a logistic regression model, if it saw that, it would just want to predict everyone as not having HIV, because that's a lot easier. We would get a 98% accuracy with that. And then another obstacle was that 27.5 of the patients were missing Parkland information. So they did have a primary MRN from Parkland. They just didn't have social history or encounter data between that time range that we had. So to deal with that, I used KNN imputation, and what that does is it looks at a patient that is missing data and then tries to find another patient that's similar to them but does have that data filled out, and then fills in the missing patient's data with that known person's information. And then to deal with the 1.9% of the patients that had a positive HIV test, I used SMOTE augmentation, which stands for synthetic minority oversampling. So it takes that 1.9% of patients with a positive HIV test and then creates synthetic data points to increase that number and make the model pay more attention to them. And with that, I fed it into a logistic regression model and got some results. So right now, my specificity is 81%. That means that of all the patients that had a negative HIV test, the model was able to accurately predict them 81% of the time, which is okay. Our sensitivity was 58%, which is not great. And that's kind of the opposite of the specificity. It's looking at, of the patients that were positive for HIV, it was able to accurately predict them 58% of the time. That's what's really important for this project. We want to get the people that need PrEP the medication that they need, and we really need to be able to identify all of those patients. The balanced accuracy was 69%, which is just the average of those specificity and sensitivity. So you can see on the confusion matrix, that's where we're getting all of these percentages, these metrics from. That really big number, 4,700, that's what's driving up that specificity. So it's predicting a lot of the negative HIV patients accurately. And then even though the false positives are 1,000, that specificity is still high because there just are a lot of negative HIV patients. Unfortunately, in this context, that means that a lot of resources would be wasted if we're giving all these 1,000 patients PrEP, even though they're not necessarily predicted to be likely to get HIV. The bottom row is where we're getting our sensitivity from, and so we're only predicting 35 people for being HIV positive accurately. And even though only 25 people are HIV positive and they're not accurately predicted, that's still a big proportion of the people that we do know end up getting HIV. So where those numbers came from were the top features that went into the logistic regression model. A lot of them are STD count, so that kind of makes sense if you think about it anecdotally, kind of a person's being more precautious and getting tested for things, so they're maybe less likely to get HIV. Unfortunately, none of these 10 features came from the Parkland data. The first one that we did see was ranked 37 out of 300. We were able to get 52 features. Unfortunately, it had coefficients of 0, and 5 of them were new features, which isn't horrible considering that I gave the model over 300 features. This is the ROC plot. Ideally, we would have an area under the curve closer to 1, and it would look more like a right angle. You can see it's kind of curving upward, but definitely some areas for improvements. In terms of next steps, like I mentioned, more features and feature selection, getting rid of those 53 features that had coefficients of 0 and were not impacting the model a lot. Getting more features from the Parkland side, there's things like labs data that we could look at. Also exploring other models, something like a random forest might be better at predicting imbalanced class weights and should definitely be explored more, and then testing on an external data set to see how the model would perform. Thank you all for listening. Thank you to the PCCI team and the Sachs Foundation, and also thank you to my mentor, Reshma, who saw me through this project and its ups and downs. Any questions?
Thank you for the presentation. I had just one question on the matching criteria that you use from hospital to the county. Was there any filter criteria based on the age? Like, was there like juvenile included, or was there any age factor that was considered before the match?
Our cohort was only adult patients, so we
Okay.
didn't have anyone under the age of 17. And then I also did blocking by date of birth, so they should be the same age.
Got it. Okay. Thank you. Mhm.
Yeah, it's a big challenge when you get arrested and booked. They ask for your, driver's license, name, social security, and you fill it out in a form. And lo and behold, a lot of people lie. Yeah. Other questions?
Not a question, but it's a comment. Farona had a challenge, is that there was a change of plan in midst of her internship. So she was working on a different project with a similar data, but totally different problem. Halfway through her internship, we had to switch over to this project. So this has been done in a very short period of time.
Just wanted to make a comment. Thank you again for the presentation. And you mentioned while talking about the metrics, 58% sensitivity didn't seem so great, is what you said, I think. But I felt, having worked in the space in this specific problem, I think within the scope of time you had, that was pretty good. And even the challenges you have with the data, I understand how challenging it could have been. So good work on that. So just wanted to make that comment.
Thank you.
And Verona, if you had a magic 8 ball and could add any additional data element from anywhere, what would you add to make this better?
I would add, other than more patients with HIV, just to have more data like that. I'm not sure, maybe more labs data. I mentioned that from Parkland Hospital. That would be good to see.
Yes, so my question, it's kind of the same thing, that if you go back to that percentage, the results, um, yeah, right there. So like here, in order to fix or I guess get the sensitivity better, I mean, how would you, I guess, how would you fix that or get that better? Is it just more HIV positive patients, more data? How would you, I guess?
There's some other things I could look into. There's like with the logistic model itself, you can change class weights, and I tried that out separately and it got similar results to that, but I didn't try that in addition to the SMOTE. And then there's also changing the threshold, which I could try that out as well.
Thank you. Next up, we've got Bengasu.
Hello, everyone. Sorry about that. I just had to do some setup. It's good to see you all, everyone here today. It's good to have people listening. I'm really excited to present my project because I love my project. I think it has a great possibility in the future to create an impact. So my project is called, I can just take this out, I think. I'll be moving. All right. My project is called Model Monitoring Dashboard. And I've been working on this for the past 3 months, and I'm hoping to be able to express how excited I am about this project with my presentation to you. But before getting into details, I will introduce myself. My name is Bengisu. I am an international student from Turkey. It's the third Turkish people here today, I know. It's interesting. And I'm majoring in data science and minoring in computer science and business analytics. I have an associate of science, and I enjoy volunteering, leadership. I am obsessed about music. And fun fact, I speak 3 languages, Turkish, English, and Spanish. As you can see, my brother and I are holding the pizza towel really well. That's perfect. All right, moving on with the table of content. Today, I'll be talking about the goal of the project, specifically why is this important, and the methods and materials I went through, which are the tools and challenges, and the current work I have, which is about showcasing the dashboard I have so far. And I'll be talking about the next step, some possible future improvements for the dashboard. All right, so this model monitoring dashboard aims to monitor behavior of the predictive models that impact patients' health. As these predictive models are taking some role, are supporting the clinical decision support system, in some cases, even life and death decisions, it's crucial that we take care of these models to make sure we're doing accurate predictions. Before moving on, I want to take some time to emphasize on the importance of monitoring, especially today. We all probably hear a lot of AI, Gen AI, LLMs going around, more than we used to hear previously. So it's becoming more and more popular. But as our CEO said, it's not new. It's just becoming more and more popular these days. It's in an article published in the National Library of Science. It's estimated that in 2026, the cost of health care can be reduced by 150 billion US dollars by using AI. So that shows how crucial it is to implement AI in healthcare in many areas. Therefore, with this increasing implementation, we do need to take care of it, as it can cause some misunderstandings while doing some predictions. It's as us as predictioners, it's paramount that we take responsibility to make sure that our models are effectively working. And here's the quote: "With great power comes great responsibility." Therefore, it is our responsibility to make sure. It's a model deployment flow. It's not done without the monitoring step. Therefore, we need to keep judging, monitoring, and interfering with our models. It's basically asking, is it working? How accurate is it? And what can be improved? Okay, how is this dashboard going to work? It's basically going to work by monitoring the model catalog, the model impact, the data performance drift, and the fairness and equity. This is like a quick summary of what I have on my dashboard as, for now. And I'll be going in more details when I move in with the next slides and showing my dashboard. And the goals for this project is we want to create a high level of summary for the model data using model specific information. And secondly, I think one of the most important goals is to have a standardized, flexible, and easy to use dashboard. I want to emphasize on this because we all know that PCCI has many models running within Parkland right now. Those are like impactful. But if we wanted to check how well they're doing, would it be efficient to create separate dashboards for all of that models? Or would it be great to have a single dashboard that would have all of the models in it? I think the second option is better. Okay, I'm a visual person, so I put this visual here to give you better understanding of the model deployment flow, it's basically, again, PCCI has models running within Parkland. Patient data is entered to these predictive models. And then according to these data, the models make some predictions. After the predictions, by consideration of healthcare personnel, some treatments are done and we have happy patients at the end. That's the overall goal we're looking for. But obviously this is not a single linear flow. We have to add the monitoring step to make sure that everything is working effectively. Again, model deployment steps are not done if there's no monitoring. So I kind of wanted to show what part of this flow I was working on. I was working on the monitoring step of this overall flow. And what this monitoring does is it takes prediction outcomes as a data set and then uses the data we have there as for the monitor input. And we're basically observing how well is the model doing. And according to those results, we make some comments, such as, is there any performance drift? Is there any data drift? And if we see some, let's say, errors, possible errors, we make some improvements to our models and we keep the flow going healthily. So basically the equation is good model with good data, which is really important, causes a good prediction, and we have happier patient. Again, that's overall our goal. Some methods and materials I've been using during this past 3 months. The tools I've been using are Power BI, Databricks, databases. I use the databases, and then I learned DAX calculations and Python. And I want to mention that most of these tools are brand new for me, so I had to learn them from scratch. But I appreciate the opportunity to learn. Now I have some more stuff to put on my resume, I guess. And the data sets I used while building this dashboard is, I first started with the open source diabetes data set, which I used it as an example data set while I was getting used to Power BI, and I didn't even know how to import data sets. I used this data set to make sure I learned the steps to build a monitoring dashboard. And next, I received the trauma data set. Now things are getting real. This is a real data set from Parkland within the PCCI and Parkland collaboration. So this is from a model that PCCI deployed, and it used real patient data. And of course, there were some challenges that turned into learnings during my internship, which are definitely learning the tool. At first, my fellow interns were all working on Databricks. They were so cool. And I was like, wait, what am I going to work on? And then I was like, okay, Power BI is my main tool. So I feel a little left out, but it's okay. So they had some discussions during the internship, like, oh, I'm facing this with Databricks. Do you have this? I'm like, I don't have that problem. Like, I don't face that problem. Sorry. So, but it's been amazing. I've learned from their experience about Databricks too. So it's collaborative. So yeah, learning about Power BI, I had to learn about DAX calculations, which we needed to create some measurements and metrics for the monitoring. And while I was learning about Power BI, I had to find some reliable resources to learn about it, because not every sources have updated information, because Power BI frequently updates. So I needed to find the most reliable source, because I found a solution and then I go to my Power BI desktop and I'm like, this is not working for me. So I think that took some time. And one of the most important challenges, which aligns with our project goal, is finding how to create measurements or metrics in a standardized way, so that whenever we have new models with this dashboard, again, this dashboard is not model specific, it's going to work with many models. Finding a standardized way to create that measurement, and then importing the graphs and charts we're going to deploy. So that took some time, but one thing I learned with Power BI, if you find the way you're going to do it, let's say I had to climb to the top and I was struggling to find the way to do it. After that, everything was like easy to implement. So I'm happy that I've learned that about Power BI. It's not that hard, but you just have to find the best way. And the timeline during my internship, what I went through, I started with some exploring. This is exploring the data set, the concept, understanding what these models are doing, because healthcare was new to me and healthcare terms were new to me. Therefore, I had to understand the overall mission, because I'm a person that whenever I understand the mission and I see the great impact, like, I am motivated for that work. So but after understanding those, I did some learnings. Again, mentioning it, Power BI learnings, and some specific terms and data sets, and how are we going to do this? And then I started building the dashboard. This includes implementing the visuals, creating metrics, measurements, as I mentioned. And the designing is the visualization part, which is for the user experience. Okay, all right, I need to stop that. It's gonna go. All right, 1 second. Okay. So before starting with showcasing the dashboard, I want to mention that my mentors and I discussed about our possible target audience for this dashboard. And then after analyzing the possible target audience, we needed to implement the pages accordingly. What I'm talking about is, as you go further within the dashboard, the level of complex analysis increases. For example, this homepage is really important because just by selecting the model, you can immediately see how well the model is doing. And what I mean by that is, by analyzing the RAG status, the red, amber, and green status, we can also see the model type and the model tier. And some great features we have I'll be showing how it's done. We have the page tracker, and we have the refresh data for the user to get the most recent data. So this is a quick overview of how it'll work. Can everyone see? I don't know. So yeah, another important feature with this page is that whenever we select the model name, the rest of the pages update according to that specific model, which means we have some analysis metrics in the next pages, but we want to filter all of them according to the model we want to see. Therefore, that feature is really helpful. I'm showing it here. For example, now we're observing the example data set. And then when we go back and select the trauma data set, this page updates. We see the RAG status again. And then the next page updates. This is same with the other pages as well. Here, I wanted to show how it updates. Yeah. So this is the home page. Moving on. Okay. Yes. Moving on, we have the impact page next. This page is important in determining if our model is still working or not. We can easily decide if we were to see a cut in predictions, we would be like, okay, the model stopped working. What's the issue? And then we could go back and to see what improvements can be done. This page again has some great features, such as showing the total predictions, which is the total encounters. Sorry. Spoilers. Total unique samples, which is the number of patients. And its great feature is that we can select the date range we want to observe the prediction for. That's how it's done. And then also the total prediction. We can see between that time range how many encounters were there, or the unique samples. Okay. So moving on with the model and data page. This is where the analysis is getting more complex. This page shows us, we can make the comment of, is there a drift in our prediction outcomes? Like, for example, if we saw a really high difference in here, there would be a problem and we would have to go back and make some changes, possibly. Again, this page is easy to track the model we're reviewing, and we can filter the sample type, the production data. We can filter the outcome class we want to see. And the donut chart here also, sorry, another spoiler, okay. The donut chart shows overall numbers, while the chart on the left shows more specific data. Again, there's all updates accordingly. We can also track what model we're reviewing on the graph. They have the model names. And the equity page, this is a page that is being still improved. I was still working on it, but I think this page is really important. What I mean by that is we're working with healthcare, data. That is really sensitive in terms of commenting about ethnicity or commenting about sex and age, because patient data is sensitive, sorry. And then we have to be able to track those metrics to see if our model is biased, and then to see if we can go back and do some improvements to it. We have the balanced accuracy score as well, and the accuracy score. And we have the confusion metrics to analyze. And I want to mention that in a study done, it was found that for a healthcare management eligibility, Black people had to have one more chronic illness than other people to be eligible for healthcare management. So I want to emphasize on the importance of knowing that our model is working equally for every race, ethnicity, or age. So this page is really helpful in showing that. And some next steps, starting from the equity page, some other measurements could be added, such as performance drift, data drift, pipeline health, is it working or not, and user behavior feedback and statistical metrics. And the user interface design needs improvements, and we need to improve time efficiency because we're working with big data. We have to make sure that it's not slowing down, the dashboard not slowing down. And a data-driven email subscription, this is to warn users and managers whenever there's a issue with the model, or whenever the model stops, let's say, we need to send a warning so that everyone is warned about it. Thank you so much for your time, for listening to me. I want to thank my mentors, Alex and Arun and Albert. And I want to thank everyone, but I don't think I have time. So I want to thank all PCCI team. This is such a great opportunity. I really grow as a person, as well as maybe data scientist. And I just want to say I really enjoyed my time. We were so included. We were treated as not intern, but like you are someone here. So I really appreciate that opportunity. And I won't forget our little discussions, not little, sometimes it took more than an hour, but little discussions done in the coding room. So thank you all so much for listening.
I'll make one quick comment. So I know we showed an example in the trauma data model, but we have an inventory at Parkland, and there are 86 identified predictive models that are implemented in some stage or about to be implemented at Parkland. And what she's done here is create the template to take all predictive models, require all vendors, require all models that are homegrown or created to fall under the same template in that drop-down list. So that's one of the goals that we'll be having for the remainder of this year. So it's really an exciting project that's going to be used institution-wide. Any questions?
Thank you for the presentation. This data was good. So I just wanted to have one question around it. The data drift part, are you also considering for future having a comparison between the model to see version-wise how the data drift is happening over a period of time?
Comparison between models? Am I understanding?
Yeah, it's between the versions of models. So if you upgrade to
Yes.
a new model, yeah.
Definitely. Power BI has great tools to do that. There's a lot of great possibilities with this dashboard, and I know it's going to be continue. So I'm really thankful that I was able to contribute to the start of this project. I think it's going to have a great impact.
So, and Vinci, not just the model version, but also the variable inputs. So every variable that goes into the model, as well as what she demonstrated here, which was the model outputs. So we track it on both sides. It's good. I think we have time for one last question, if there is one.
Really good job here. What was the hardest thing that you found to standardize between the models in order to make sure that you could produce these consistently?
Yes. So as we all know, different models have different metrics or different outcomes. For example, the trauma data set predicts high or low possibilities, and the example data set I had predicted negative or positive. So I needed to create a measurement that was going to compare the ground truth with the prediction outcome, but I couldn't do that by, having negative or high measurements in my calculations. That's why my mentors and I discussed about this, and then I had to find standardized measurement, but I think I did find it. So there's a way to do it.
Yeah, and in future iterations, some are low, medium, high, very high.
Yeah.
There's going to be different outputs that all need to be treated in a similar way. Thank you so much.
Thank you.
Our final presentation for the morning is Autumn.
Okay, I am going to present to you brain care today. This is a new project at PCCI, and I have had a lot of fun getting this off the ground. So a little about me. I am from Ohio State, or the Ohio State, as Steve corrected me in our first Power Hour meeting. I received my bachelor's from there, as well as my master's in epidemiology, and decided to stay around and finish out my PhD there as well. My PhD is in epidemiology, but I focus in pharmacoepidemiology, cancer epidemiology, and translational data analytics. And I am expected to finish that at the end of the year, so I'm very excited. I've worked in a lot of different avenues of research at Ohio State. I've worked as a research coordinator, working with patients, clinical trial implementation, as well as a research associate and teaching, which I will be going back to teaching at the end of this month, global public health. So I'm very excited about that. So I'm going to walk you through brain care, give you a little bit of background on that, my methods, results, and then next steps for whenever I give this project over to Sandra. So the objectives. So the first is to understand and explore the Alzheimer's disease and related dementia population here at Parkland. Our next objective is, can we really predict if a patient will develop Alzheimer's disease or related dementia within 12 months using EHR data and the social determinants of health? And then finally create a geographic risk surveillance map of highly vulnerable areas where Alzheimer's disease and related dementia may occur more frequently, pretty similar to what you've done with pediatric asthma. So the long-term impacts of this are really to be able to target prevention towards those who are greater at risk, to identify those who should be monitored for new symptoms, and to identify and initiate treatment at the earliest possible stage. So I'll give you a little bit of background here because most people use Alzheimer's and dementia interchangeably, and they are two very distinct conditions. So dementia describes the symptoms. So it's a loss of cognitive function, thinking, such that it starts to interfere with a person's activities of daily life. So this can be memory, language, visual skills, ability to focus and pay attention, problem solving as well, whereas Alzheimer's disease is the most common type of dementia. And it's an irreversible progressive brain disorder caused by many understood and not understood yet complex brain changes. These symptoms usually develop slowly and get worse over time. And you'll see here, this is really the 5 stages of Alzheimer's disease. Most patients are diagnosed here at the 3rd stage, which is early stage, whenever those symptoms start to interfere with daily life. And the earlier we intervene, the better outcomes and the longer lives these patients can have, and longer life with a better quality. The risk factors for this are really genetics, lifestyle over not just currently, but over the course of one's life, including education is a big one, and then environment as well. It's really diagnosed by a comprehensive evaluation of health history, physical examination, blood tests and scans as well. And treatments, there's not anything, Alzheimer's disease and related dementia is not curable, but there are treatments, like I mentioned, that can help memory, cognition, and slow the progression. So who does this impact? Alzheimer's disease impacts about 7 million people in the United States and about 500,000 people over 65 in the state of Texas. It's the 6th leading cause of death, and it's projected to grow, and there's significant disparities that exist between different sexes, race, and ethnicity, and those disparities are also projected to grow. So to accomplish the objectives that I mentioned, I used 2 data sources. So the first being the CVC, and then the second being Parkland's EHR records. So we identified cases based on ICD-10 codes, and then also the administration of a medication to treat Alzheimer's disease and related dementia. We identified about 15,000 people. We identified about 40,000 that had developed Alzheimer's disease and early dementia, but we narrowed it down to these 15,000 just based off of missing data. And those were matched to individuals without Alzheimer's disease or related dementia based on age. And we really looked at the demographic variables, comorbidities, and 12-month encounter history. So to explain the matching a little bit more, so here is essentially the study timeline. So we took patients, you'll see their first encounter at Parkland and then their last encounter. So we identified where the first Alzheimer's disease diagnosis or prescription was made, and then looked 12 months back for a prediction window. And then we did the we matched these to the controls based on age, and then looked at their 12-month history as well for encounters. So let's get into the results here. So the first is to understand the population. The individuals that were in this cohort, they had about an average age of 65. I didn't include that here because I didn't include it in the model just because of the age matching. So most of the individuals in our study were male. You'll see most of them, I think these colors are off. Anyways, most of them were white, even though that's not correct here. Most of them are Hispanic, smokers, and then which falls in line with a lot of history of what causes Alzheimer's and dementia. Smoking is a big risk factor. Most of these individuals were, I think my colors got mixed up here. But anyways, most of them were married. And then the last thing we also looked at, well, not the last thing, but we also looked at their comorbidities, and we did this by using the Charlson Comorbidity Index, which essentially is a measure or an index measure of chronic illnesses that a patient has. It takes into account our liver disease, renal disease, paralysis, dementia, CHF, COPD, diabetes, HIV, and cancer. And you'll see here that this comorbidity index was much higher among those with Alzheimer's and dementia as compared to those without. And then the healthcare encounters is the other thing that I mentioned that we included. So the key areas that were identified by our stakeholders to be important in this analysis were their encounters with mental health and neurology. And you'll see here that about 5% of the Alzheimer's and dementia population had an encounter with mental health. This is much less among those without. You'll see that about 21% had an encounter with neurology, and 4% those without. You'll see a significant number of these patients had an emergency department encounter, both among those with Alzheimer's and dementia and those without. And then about 34% had a hospital admission, and among those with Alzheimer's and dementia, and about 10% in those who didn't. You'll see here, this is looking at the CVC indexes between the two groups. So those you'll see in the first column with Alzheimer's disease and dementia, and then in the second column, those without. And you'll see that those are pretty similar across the two groups. So next, moving on to seeing if we can predict if an individual will develop Alzheimer's disease within the next 12 months. So we did this 2 ways. So the first way, we use Lasso to select predictors, and then looked at the accuracy of that model. And then we also looked at decision tree models. And then we did it in 2 ways. So we applied both those models to just looking at demographics and CVC, and then we applied those same models to demographics, CVC, the comorbidity index, as well as the healthcare encounters. So the first one here that we'll look at, this was the worst model so far, and it was the decision tree, just looking at demographics and CVC. But you'll see here that the here on the left is the marital status, smoking status, neighborhood index value, education, unemployment, equitable communities, walk score, disease burden, ethnicity, race, and Dallas County residents were the highest, lowest predictors. And then the accuracy of this model was about 70%. The third worst model was the LASSO, and just using demographics and CVC data as well. These variables here were the predictors selected by LASSO to be the most important, and you'll see here that this one had a similar accuracy of around 70%. Our second best model was LASSO, including demographics, CVC encounters, as well as comorbidities. And this had about an accuracy of 75%. And then you'll see here, the LASSO predicted or selected predictors are a little different. These include paycheck predictability, neighborhood safety, clean air, alcohol abuse, cancer, and disease burden of those communities. And then this being our best performing model, this was the decision tree, including demographics, comorbidities, encounter history, and CVC data. And you'll see here, again, the predictors are listed from highest to lowest. Some of the most important predictors of this model were comorbidity index, neurology encounters within the last 12 months, hospital admission,
ultra fine, they can get into our brain, cause inflammation. So I think that whole in predicting those neighborhoods, so many of those zip codes you highlighted, actually they're ones where we're also measuring the aerosols in real time. They are quite highly polluted because of their proximity to large sources. So that is probably an actionable thing that can be improved. So the prediction is both valuable to help an early intervention, but it's also valuable for longer term improvement of cognitive health over the region.
Absolutely. And that's kind of one of the things that one of the bigger takeaways and surprises to me was I knew how important environmental factors and air quality and things like that were on Alzheimer's and dementia. And it was really interesting to see that proven here. Oh.
Yeah, so one question on the factors that that are, I guess, the highest rated factors that you have. Yeah, so like there was no I guess a factor of like activity status or like for like patient individual. When I say activity, I mean like working out or whatnot. And but have you done any research on that to where a patient or individual works out or more active than others, he or she has like a lower percentage?
No, I think that would be a really interesting thing to look at, but that's something that's not necessarily captured in the HR data. One thing that's similar to that activity could be an interesting one if it was captured, but I also know that like education would be a really interesting thing to include here.
Yeah, I think in the future, if wearables and IoT device data gets put into the EMR, I think it'd be real interesting to see, but it's just not available.
So the interesting thing about the wearables, together with the airborne pollution, in a study we did for the Army, we found that from the real-time autonomic response that we can measure with wearables, we can infer the inhaled concentration and size distribution of particulates and different gas concentrations. So you can have essentially a redundancy. You can have a set of wearables that are giving you an estimate, a very accurate estimate of inhaled components of air quality, but we also have small package size sensors that are measuring in situ. And so that is really exciting because these are going together. So, but then you also have the activity and sleep, and the sleep obviously is a really important.
And not only applying that to Alzheimer's and dementia, but I think that that same idea could be applied to so many other health conditions that I think would really improve some outcomes in the long term.
Thank you, Autumn. Thank you again to all the interns and the folks and everyone for coming out and for being on the call. Steve, any final words?
Just again, congratulations, a huge thank you. Those of you that have had the opportunity to see these presentations year over year, this was impressive. Not only just the work that you've done, but I think the diversity of the projects. This is like some projects like this last one that kind of took it on from scratch. Some of the foundational dashboards. Really meaningfully advancing some of the work that's been going on for years. So congratulations for just also having the flexibility and the willingness to step out of your comfort zones, because we've done that with you. And that's what I think makes this so special. So a huge thank you to everybody. Thank you for joining us. I know, taking 3 hours out of somebody's day is a long time. And not only all of you here in the room, but those online, thank you for sharing these achievements with us, and we're so excited to see where your careers go.